Welcome, everybody. My name is Marty Mascari. I am a contractor with the North Central Texas Area Agency on Aging and the North Central Texas Aging and Disability Resource Center, both of which are under the umbrella of the North Central Texas Council of Governments in the greater Dallas-Fort Worth, Texas area. Um, we are blessed first to have a partner of ours of the Alzheimer's Alliance of Smith County. We partnered on. I know we're partnering on a dementia friendly grant, and so we're thrilled to have Rebecca here with Smith with the Alzheimer's Alliance, and then we have Julie Adams here with Christus, who's going to be our speaker today. But before we get going, if we could advance a slide one, and I'd like to go over the CEU requirements for today. The first thing we're going to ask you to do is to make sure that you complete the pre-webinar test. And I've put it in the chat a few times. I'll put it in the chat here right now as we and please make sure you do that. That's a grant requirement of ours in order to be able to report back the information that we're required to on the grant. But thank you, Julie. We've got it now. Thank you. So for those of you that are joining us today that are looking for CEUs or for a certificate of attendance, we are set up today to provide complimentary CEUs for licensed social workers and licensed professional counselors within the state of Texas. Now, if you have a different license in Texas or you have a license outside of Texas, you are more than welcome to go through the same process, and we'll issue a certificate to you. And you're more than welcome to submit that to your jurisdiction, whoever your licensing jurisdiction is. But please note, we don't have any leverage to get them to take that. But I have had people tell me that they've been able to use them. So I welcome you to go through the process. And I have had some jurisdictions actually reach out to me wanting more information on the webinar we put on to see if they felt like it qualified. So you're more than welcome to have them do that as well. We're also offering certificates of attendance for anyone who would like one. And the guidelines for the certificate of attendance are the same as they are for the CEUs. Today's webinar is with 1 hour of CEU credit. You must complete the entire webinar live and the Q&A to be eligible. You also must complete both the Google evaluation survey and that form should pop up as you close out a Zoom today. It should give you the invite to take a short survey. If that doesn't happen, please, no worries. That will go out in a follow-up email with more information after the webinar, and that will go out later today. There are also the pre and post tests. We ask everyone to complete all of these, but for those of you looking for CEUs, that is a requirement. So the link to the pre-test, I've not only sent out with your login information, but I've also put it in the chat, and I'll continue to do that for the next few minutes for any of you that are logging on and since I put it on last. The survey links, again, will be sent out in the follow-up email. They'll be open for 1 week from today to the 5th of July, and then give us about a month to get those certificates out to you. That takes some time, and so if you can have patience with us to get those out to you. But after August 5th, if you haven't received it, please feel free to reach out to me, and we'll make sure there's not an issue or something that's gone on. So I would, if we could advance the slide again, and we are thrilled to have Julie Adams, and she is with the crisis healthcare system, and she's going to talk to us about the fall risk in dementia. And I'm going to turn it over to Julie.
Thank you, Marty. Good morning, and I'm so pleased to be here to talk to you about something near and dear to my heart. Our patients living with dementia who are hospitalized and their special fall risk that we can help protect them from. So thank you for joining us. My goals today are to help define dementia and identify how the most common causes of dementia impact mobility, how to recognize the signs and symptoms associated with each stage of Alzheimer's dementia, and to identify risk factors for falling in people who are living with dementia, and finally to implement strategies to reduce the risk of falling in the acute care setting. So everyone has a why, and we all have a why we work in healthcare, why we're here today to discuss fall prevention in our hospitalized patients. My mother is my why. She was diagnosed with Lewy body dementia in 2017, and it was quite a journey. Interestingly, after a very long career in as a nurse practitioner and an RN, I had just come to the neurology setting about the time that she was diagnosed. So I think perhaps that was a divine intervention that happened. And I hope that as we go through this today, it helps you remember your why working with these patients. So how do we define dementia? It's important to know that dementia is a general term. It's progressive loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. Alzheimer's is by far the most common cause of dementia, accounting for up to 80% of all diagnoses. One thing I think can be confusing, especially for our patients and their families, is understanding that dementia is an umbrella term. There are many types of dementia. So I always say it's sort of like dessert. You know, there are many types of dessert, except this is not a dessert you want. You know, you could have a cupcake, you could have a cookie, you could have a candy bar, you could have ice cream. Well, you could have Alzheimer's or Lewy body dementia or frontotemporal dementia. So just, you know, understanding that dementia is a general term for a variety of different disease processes. So dementia occurs when a disease causes damage to brain cells and the neurons and their ability to communicate with each other. And depending on where the disease is active in the brain is going to dictate the symptoms that you see in the clinical setting. So when it's more in the hippocampus area where Alzheimer's tends to begin, you're going to see memory impairment because the hippocampus is critical in taking those new short-term memories and filing them away, holding on to them so that they can become long-term memories. As a disease progresses, such as Alzheimer's, and more unhealthy proteins that cause tangles and plaques and disruption in how neurons talk to each other, you're going to see more of the brain become involved. And as more of the brain is affected, depending on where the disease, you know, that what that part of the brain is responsible for is going to dictate the symptoms you see. So you'll start to see issues with judgment, visual spatial relationships, executive function like organizational skills, focus and attention, and ultimately you'll see problems with movement. So because Alzheimer's is so prevalent, when we're talking about our patients living with dementia, I wanted to spend a little bit more time going over the stages of the disease. There is the preclinical phase, which can last as long as 20 years before physical symptoms are seen. And this is where there are physical changes occurring in the brain that are going to likely end up leading to Alzheimer's disease. Not everybody who has these changes ultimately develops the disease, but it's a process that can be detected as long as 20 years before symptoms would show up. And that's the preclinical phase. Then you have the mild cognitive impairment. With Alzheimer's disease, that mild cognitive impairment is going to be very memory heavy. So the complaints you tend to hear are going to be the spouse says, my husband repeats the same question over and over again. I tell him the same thing, and 5 minutes later, he's forgotten. So you really see those short-term memory issues in that mild cognitive impairment. And they can be sort of annoying, but people are often functioning very independently, still working, but there's some changes that often the individual and their loved ones can detect. And then you actually get into the stages of Alzheimer's dementia, and the mild or early stage, the symptoms are starting to interfere with everyday activities. People may start having difficulty at their workplace. Oftentimes, this is where they're having more trouble keeping up with their work, and just noticing things that, like, they're maybe a trainer, and all of a sudden they're having to ask people they've trained to clarify some things that they used to know like the back of their hand. Then we go into the moderate stage. This tends to be a very lengthy stage, and these symptoms are now interfering throughout the day with their functioning. Usually this is where they shouldn't be driving anymore because the risk is high that they could get disoriented or perhaps have difficulty making good decisions, safe decisions. And then the severe stage of Alzheimer's. And this is the most challenging stage because this is where people really begin to have problems. Maybe they're forgetting loved ones, or they're starting to lose their ability to express themselves, or even at the latest stages, remembering how to feed themselves. So just wanted to go over those stages. So why are we focusing on reducing fall risk? Well, falls are common. Falls in the hospital, unfortunately, are more common than we would like for them to be, even in patients who don't have dementia. So it's a good focus. They're one of the most frequently reported incidents in adult inpatient units, and between 700,000 and 1 million people just in the US fall while they're in the hospital. And falls are one of the leading cause of injury-related death in people over the age of 65. And they lead to increased healthcare utilization because these folks are often more apt to be injured in their falls. And that's just patients in general. We're not even talking specifically about dementia patients at this time. So falls are even more common in our patients living with dementia. Some estimates say 4 to 5 times more likely to fall than people without cognitive impairment. There are some sources that say up to 8 times more apt to fall. In those who do fall, the risk of sustaining a fracture is 3 times higher than their age-matched cohort who are not living with dementia. And they're 5 times more likely to be institutionalized. In other words, not go home, lose their independence. The other thing we have to consider is that beyond just losing independence, which is huge, that fractures, especially fracture of the hip, is associated with significantly increased risk of mortality. The latest estimate I could find is that if a patient has a fall and breaks a hip, they have a 27% increased risk of death in the next year. 1 in 4, more than 1 in 4, right? There are many, many things that work against our patients living with dementia who are in the hospital. For one thing, they already are living with cognitive impairment, and now they're sick. They're apt to have delirium on top of dementia, be very confused, physically weak. They may already have pre-existing gait changes, visual disturbances, poor balance. They may be more prone to syncopal episodes and often have more frequent and urgent toileting needs. Their judgment may not be the best. They may be impulsive. Obviously, we can educate them all we want and we should, but they may not be able to remember the instructions because of the memory impairment. Just as we age, we're prone to having visual changes and hearing changes that make our patients who are already struggling with taking in new information or expressing themselves. It interferes with that, and it also, they're in unfamiliar surroundings, and having those impairments can make them feel even more confused. They're also more prone to polypharmacy. And we know that patients who have dementia who take more than 5 medications are at higher risk of falling. Well, how many patients have you taken care of in an acute setting or, inpatient setting who are on less than 5 medications? Then certainly if they have a history of falling, we know they're at high risk. There's comorbid conditions that can occur with dementia that put them at higher risk of falling. Perhaps they're in the hospital, they've had a stroke, an acute stroke, or they have a history of a stroke with residual weakness or balance vision problems from that stroke. They may have a seizure disorder, an arthritis condition that makes them stiff and interferes with their balance. They've had an acute fracture or old fractures causing, stiffness, pain, change in gait, diabetes, sudden changes in blood sugar, fluctuations, the tendency to have diabetic neuropathy really puts them at higher risk. They have a vitamin D deficiency. We know that is a risk factor. Anemia, if someone is anemic, they're not getting adequate oxygen being carried to the brain, and the brain misbehaves. If it's already struggling, it really sets them up for being more confused, and also for being, weak, lightheaded, short of breath, and more prone to falling. If they have a heart rhythm disorder, I already mentioned neuropathy from other reasons, as well as diabetes. If they have a high BMI, poor quality sleep, sleep apnea, urinary incontinence, and if they just had a recent hospital discharge and they're right back in again, we know that's a big risk factor for falling as well. So I've sort of focused on Alzheimer's to this point, but I would like to focus in on some of the most common types of dementia you're apt to see in your patients. After Alzheimer's dementia, there's some debate about the next most common type of dementia. Oftentimes, sources will cite vascular dementia. There are others that will say Lewy body dementia is the second most common, but we're going to talk about both. With vascular dementia, this typically happens in our patients who have had a large stroke, or maybe multiple small strokes, or who have chronic microvascular ischemic changes in the brain. So microvascular ischemic changes are not necessarily, they're not strokes, but they're damage to the teeny tiny ends of those arteries. And it comes from things like high blood pressure, uncontrolled, diabetes, smoking, all of those vascular risk factors, high cholesterol. And if you get enough of that teeny tiny damage, then you are not getting as good quality oxygenation and nutrition to the brain. So even if this person hasn't necessarily had a big stroke or multiple little strokes, if they have enough of this microvascular damage, you can see changes in cognition. With vascular dementia, it looks a little different, where Alzheimer's is very, you see a lot of short-term memory problems. It's very consistent. It's gradually getting worse over time. Word finding difficulties. That's sort of the focus you tend to notice in the most common presentation with Alzheimer's. With vascular, it doesn't look like that. Oftentimes we think of vascular, somebody has a certain level of functioning, and then a stroke happens and they take a step down, and they sort of have this new normal. And then if they have another event, they take another step down. Sometimes you'll hear it referred to as stepwise loss of cognitive function. And depending, the symptoms you see are often dictated by where the stroke occurred. So if somebody has a posterior circulation stroke in the back of the brain that picks on balance and vision, then you're going to see people have dramatic difficulties with visual spatial relationships and visual impairment that put them at high risk for falling. If you're seeing more generalized effects from a multiple stroke burden, then you're going to see people have issues with executive function. And that's that organizing and planning, being able to analyze information and make a decision or solve a problem, things that are often effortless, like I need to send a birthday card to my grandson, and it's just overwhelming to figure out how to complete the message, put it in the envelope, address it, get the stamp on, and get it to the post office or out to the mailbox. Like they'll forget to put the stamp on, or maybe they'll put their address their home address, like where it needs to be sent to. There'll just be these sort of missteps in that organization. You can see a slower speed of thought. So these patients, if we recognize that that's an issue, we need to speak in simple sentences, not super complex explanations, and then pause and give them time to respond. We can't go in a big hurry because we are not going to have good communication with them. They're also prone to, I mentioned earlier, their focus can be poor, concentration can disappear like that. And they're prone to periods of confusion. The other things that can come with it, again, are dictated by where the stroke occurred in the brain. If they're weak on one side of the body, and they're having a hard time being impulsive, then they're more apt to fall because they're gonna forget to use their walker. They're gonna be like, I don't need to use the walker, I'm fine. So you just have to look at the many different challenges somebody with vascular dementia faces because of the stroke itself and then the cognitive changes that come with it. Parkinson's disease dementia and Lewy body dementia, a lot of times that is, how do we tell the difference? Because Lewy body has some Parkinson's symptoms, but it starts with the dementia part early. Whereas with Parkinson's disease dementia, somebody has classic Parkinson's disease movement symptoms. There are other symptoms besides movement, but not usually cognitive impairment. You have those, and then later you start to develop cognitive symptoms. And if people live a long time with Parkinson's disease, they often do develop cognitive impairment. But the way in neurology, the way we sort of split those two diseases up is if there are problems with cognition in the first 6 months, along with Parkinson's symptoms, we're going to lean towards Lewy body dementia. If there's primary Parkinson's symptoms, and then it's more than 6 months and cognitive symptoms start to be an issue, then we're going to call that Parkinson's disease dementia. You're going to see, in Parkinson's disease dementia, the first things you're going to notice are physical changes. Bradykinesia, those slow movements, ataxic movements, uncoordinated movements, freezing, that difficulty initiating that movement, like they stand up and then they can't pick their foot up off the ground. Obviously, you could see how that could raise the risk of falling. They also tend to have a shuffling gait where it's very difficult to pick the feet up off the floor. And they have a stooped or forward-leaning posture that throws off their center of balance and makes them more prone to falling. They also tend to have autonomic dysfunction. And if you remember, autonomic are those things that our nervous system does for us automatically, like maintaining our respiratory rate, our heart rate. We don't have to tell ourselves, breathe, maybe if we're having a panic attack, right? But you don't have to be aware and tell your heart to beat or make those adjustments like our blood pressure, right? We don't control that. It happens automatically. That's our autonomic nervous system. So autonomic dysfunction is often a serious problem with Parkinson's patients. With plain Parkinson's, primary Parkinson's disease, that tends to happen later in the disease. But when it does happen, they're prone to having their blood pressure drop dramatically when they change positions, particularly from sitting to standing. And we diagnose that when they have a drop in their systolic blood pressure by 20 or more points upon standing, or their diastolic blood pressure more than 10 points upon standing. And obviously, if they stand up and their blood pressure drops suddenly and dramatically, they're prone to getting lightheaded and falling. Later in Parkinson's disease, there tends to be a big issue with visual hallucinations and a decline in thinking and reasoning skills. And they also are very prone to REM sleep behavior disorder. REM sleep is where we dream, and our brain is supposed to keep us paralyzed while we're dreaming so that we can't act out our dreams. People with Parkinson's disease are having a malfunction in that REM sleep. For some reason, our brain has lost its ability to keep us paralyzed during that very important type of sleep. And so these are patients who act out their dreams. You know, they talk in their sleep, they violently move around in their sleep, they're hitting their partner, they're knocking things off the bedside table, they may even be falling out of bed. And sometimes REM sleep behavior disorder can start as much as a decade or more before those Parkinson's symptoms actually show up. But it is strongly associated with Parkinson's disease. And you can see if they suffer with that, how that would raise their risk of falling in the hospital setting. So Lewy body dementia is a little different from Parkinson's. They definitely share features, but one of the earliest hallmarks of Lewy body disease is visual hallucinations. When we have someone who seems cognitively quite intact, they're very eloquent, they're not having a lot of short-term memory problems, things may not be perfect, but they're having visual hallucinations, we automatically think, could this be Lewy body? Because that is really such a central part of that diagnosis. These patients also tend to have fluctuating cognition. That means much of the time they're quite clear and coherent, but they're bad times. They might be staring a good deal. They might not be making sense, especially under a physical stress like an illness, urinary tract infection, pneumonia, significant pain, like maybe post-operative pain, those sorts of things are really apt to trigger these spells. Family are sometimes very frustrated with these patients because they're so normal at times. And then when they're so different and they're struggling so much with their alertness and cognition, sometimes families think that they're like they're being hypochondriacs, or they're sort of putting on, or they're not trying hard enough. And so it's really important, if a patient has this diagnosis, if you notice the family getting very frustrated, education can be really helpful, that this is really a hallmark feature of Lewy body, is they have good times and bad times. What they don't have is that consistent short-term memory loss that tends to progress and progress. Ultimately, they are going to progress, and they're going to have more difficulties with memory, over time. But it's not an early feature of the disease. Visual spatial relationships are very impaired early in the disease with Lewy body. I think that goes along with the visual hallucinations, but these are the people who have never had an accident in their life, and in the last 6 months, they've had three 3 different accidents. They pulled into the garage, they backed into the mailbox, you know, and it's because they're having those visual spatial relationships. They can see, but it just doesn't translate. The brain is struggling to make sense of it, and they're turning the wrong way, and really struggling with that. There may be some features of Parkinson's disease present, but it usually doesn't look exactly like Parkinson's disease. There may not be any tremor, which is often an early symptom of plain Parkinson's disease. I said about plain Parkinson's that you get that autonomic dysfunction later in the disease, but it's often one of the first symptoms that you see with Lewy body dementia. So these patients are falling. And you don't necessarily see them shuffling. You know, they're not in a stooped posture. You're not going, wow, something's, you know, really wrong with their movement, but their blood pressure's bottoming out. And this can happen even in patients who have high blood pressure and need treatment for high blood pressure. You know, can have episodes where they stand up, blood pressure drops, and they fall. And they also have the REM sleep behavior disorder early. Frontotemporal dementia, not quite as common, but one of the more common dementias that we see. It tends to occur earlier in life. Typically, the onset is somewhere between 40 and 60. It's really a devastating disease because it hits so hard on personality. It can really change how a person behaves, and so hard for loved ones because they can, you know, become no filter, very blunt, you know, say things that are really hurtful to people and make really impulsive decisions like gambling or hypersexuality. I had a patient with frontotemporal dementia a few years ago, the loveliest, sweetest little Mima, right? Little grandmother, and with her daughter, and her daughter was absolutely beside herself because the patient lived in an apartment, and somebody had come around to do some work on the apartment, and she had propositioned him and had sex with him, and which is not something that she would, you know, typically do. But it was that impulsive, you know, change in behavior there. Sometimes the changes that happen in the brain with frontotemporal dementia really pick on speech, and people can have profound difficulty with word finding, difficulty with that executive function, planning, organization. They also tend to have problems with visual spatial relationships. And late in the disease, it starts to look a lot like Parkinson's, where they tremor, they shuffle, they have that stooped posture, and puts them at very high risk for falling. In case you don't notice, there's a lot of overlap with these diseases, especially as they progress to later stages. It can be really hard sometimes to give a definite diagnosis. And you have to forgive me, I'm a good East Texas girl. You can have fleas and ticks. And by that, I mean, you can have Alzheimer's disease and you can have vascular dementia superimposed on that. On autopsy studies, it's not unusual to find even Lewy bodies, abnormal proteins in the brain that disrupt, similar to Alzheimer's plaques and tangles. you'll see all of these things occurring, as well as vascular changes that we know would be affecting cognitive function. So it can be very complicated. So talking about how this impacts movement and fall risk, in the earliest stage, mild cognitive impairment, you're going to have problems with concentration, possibly impaired decision making. Early stage of Alzheimer's, patients are going to be easily overwhelmed by complicated explanations. They're going to have multiple people in the healthcare field coming in and out of their room, with different focus, but telling them different things. It can be very overwhelming and make them more prone to an unsafe action. They're in an unfamiliar environment, and anyone who's struggling with dementia is going to be very thrown off by being in an unfamiliar environment. It's going to be confusing, and it can make them anxious. It can make them impulsive, and they're more prone to injury, falling. The stress of the illness, as I mentioned before, and then recognizing and remembering their limitations. It's so hard because you see family members and healthcare providers saying things like, remember, I told you, don't remember. That is not a very helpful thing to say. It tends to make the patient feel bad, embarrassed, frustrated. And does it really make us feel any better? Sometimes we're frustrated too, and we say, remember, but it's something I encourage you to take out of your vocabulary when you're working with patients with dementia, because it's not productive. It may mean you have to get creative about helping them remember. Visual cues are often very helpful with that, but we'll talk about that more in just a second. In middle stage, patients may not be able to understand what you're trying to express to them, especially if you've got multi-step instructions. They may have difficulty finding the words to be able to express themselves. They may act in ways you don't expect them to. In their mind, it makes perfect sense, but it doesn't necessarily fit appropriately with the situation. So expect the unexpected. They're unable to recall information about themselves, like, I need to use a walker now. They are more prone to confusion, especially in that unfamiliar environment. They have more difficulty controlling their bladder and bowels. Often they have urge incontinence, and they have a tendency towards changes in their sleep patterns. They're very prone to wanting to sleep during the day and then get restless at night. We call that sundowning. Then really heartbreaking thing that can happen is they can become very suspicious. They can develop delusions, which are fixed beliefs about a situation that aren't true, like they think their spouse is cheating or that their kids are stealing money from them. It can be really heartbreaking for family members, and it can be really difficult for people outside the situation because the person, it may be very eloquent about, what the delusion they're experiencing, and, you think, are they stealing from them? Are they harming them? Are they keeping them prisoner? Those are some of the delusions we see more commonly. And then hallucinations. The most common is visual across all types of dementia, but it can be other types of sensory. Like I've had people believe they had like something stuck in between their teeth, and like they were fixated on it and just sort of made family members so anxious about it because they just knew that there was something wrong, with their teeth, and they went to the dentist over and over. Anyway, you can get other types of hallucinations too. And then, of course, the stress of illness is more apt to lead to agitation in this stage. In the later stages of dementia, you are going to have extreme difficulty with the patient being able to communicate to you things like pain. So there are pain scales for patients living with dementia. I've in the notes attached to the slides, I share some of that information. You probably have one in your facility, but you have to get creative in how you assess whether someone's in pain, because it can dramatically impact their behavior and their fall risk. They may not be able to hear or see well just from aging changes, but they also get changes in their visual perception from the disease. And they're just not able to interpret their surroundings, accurately, which can lead to unsafe behaviors. And in very, very late stages, they're not able to maintain an upright posture. So they sort of slump and tilt, and they may not even be able to get up for transfers anymore, safely, but they can still move. So left unattended in a situation where they can definitely fall out of bed or fall out of a chair. So you have to really be careful with those folks that have lost their postural tone. And then, of course, they're in the hospital for some reason, and it's probably not for dementia. So, we have to balance out the needs of protecting them from a new complication, but also prioritizing why they're there and protecting them from complications. So one of the biggest complications patients can suffer in the hospital is things like a deep vein thrombosis, so a blood clot from immobility. And so many times we need these patients to be moving around, and yet moving them around increases the risk for falls, but we have to balance those things out. I need to stress here that fall prevention is not a nursing responsibility. Fall prevention is everybody who comes in contact with that patient in the healthcare setting responsibility, from the physician to the advanced practice provider, all the way down to case manager who might be coming in to work with them. So this is definitely an interdisciplinary approach if we're going to be successful. So one of the things that is recommended is that every patient coming in have a fall risk assessment. One of the most commonly used in our area is the Morse Fall Scale. And based on the score, we determine if someone is a fall risk. And a score of 25 or higher is going to get them designated as a fall risk. So there'll be some steps that every facility will have their own policy for this, but typically it's going to involve wearing a wristband of a certain color that says fall risk. There may be special socks that they wear with a special color that makes it easy to see, oh, hey, this person is a fall risk. There may be signage on the door or in the room. Again, just, recognizing that they're a fall risk. So things that we do, we call them universal fall precautions. We do this for everyone in the hospital. The Morse Fall Scale is done for everybody coming into the hospital setting. We're going to familiarize the patient with their environment. We're going to make sure they know how to use the call light and and where it is and have it within arm's reach. We're going to keep their personal possessions within patient safe reach, their glasses, their hearing aids, the remote control, their phone, whatever it is they need. We want it handy. We want to make sure that we have sturdy handrails in places where they might be up and they need additional support. Bed in the lowest position, and just make sure you raise it to a comfortable height when you're working with a patient, and also when the patient needs to get out of bed, because oftentimes these patients are weak and can't stand up from a very low position. So make sure the wheels are locked, things aren't moving around on them, the tray table, they're in a wheelchair, when they're stopped, it needs to be locked. We want to keep them in non-slip socks, and they need to be well-fitting. So many times when I make rounds in the hospital, when I'm spending time in the hospital with our neuro patients, I'll walk into a room and they'll have the non-slip sock on, and it's like up to mid-calf. It's just one's hanging off the other foot and one's up to mid-calf. I mean, obviously it doesn't fit. So make sure that they fit well, because ill-fitted ones are going to raise their risk of falling. We want to make sure they've got adequate lighting to optimize their vision. If they're already struggling with visual perception, visual spatial relationships, they need to be able to see well, particularly in an unfamiliar environment. We want to make sure we keep things uncluttered. The floor surfaces are clean and dry. Sometimes you go into a room and you'll see like alcohol pads and 4x4s and all sorts of, stuff on the ground. And not only is that just not good hygiene, but they might see that and perceive it as something else. They'll sometimes think IV tubing is a snake, or it can lead that confused mind to make up things to fill in the blanks that could be upsetting and raise their risk for falling. We also want to follow safe patient handling practices. So, making sure that if we need 2 people to, move a patient, whatever, that you have the help you need and you're using your assistive aids as needed to keep both you and the patient from safe and the patient from falling.
And Julie, just wanted to let you know that we only have a few minutes remaining. You've got so much wonderful information, but we may need to move kind of quickly through the last few slides.
You got it. The things that we can do in caring for them, we can look at their medication list. Obviously, they have a provider who's overseeing their medications, but particularly nursing staff, we can ask, could this be contributing to confusion, making things worse? Could we do something different? We want to assess fall risk routinely on admission, on transfer to another unit, and if there's any change in status during the hospital stay, as well as after a fall. And we want to educate the family, because they can definitely be our ally if they know what to look for, what to do, and why, so that they understand. We can use a bed alarm, a floor pad alarm to help alert us if a patient is getting out of bed. Side rails, there's a lot of debate about that. Of course, they can help patients move around in bed, and there's some pros to that, but they can also create anxiety and risk for our patients who are confused and cause serious injuries. We want them to dangle their legs, pump their legs before they stand up, trying to get blood pressure up, make sure they're not dizzy when they stand. We want to make sure if we're trained that we use gait belts, if that's appropriate, or that they have their assistive devices. We want to avoid use of restraints, make sure we give them a shower chair. We want to provide visual clues because they may pick up better on that. And then we may have to have a sitter to help keep them safe. So
Julie, I'm going
most
to
of you
ask.
probably know this. So
Julie, I hate to interrupt you. This has just been really good. I am so sorry to everyone. I should have. It's my fault. I should have scheduled this as an hour and a half webinar and instead of an hour. And I certainly apologize to you and to everyone else for that. But I think we've got a lot of people that have on that probably have other commitments. And so
yes.
If you don't mind, we're going to stop here real quick and go over
Sure.
the CEUs, make a couple announcements. And what we'll try to do is the questions that you all have in the Q&A, I will, I don't know, Julie, if you have time to stay on and try to answer those
Sure.
after the time, that would be great. But if we could go down to the CEU slides and just go over that one more time for people that might have to get off because of other commitments.
The very first one or
the last one. Go to
okay, last one.
Yeah, the last slide.
We were down to the quiz.
Oh, there you go. I'm so sorry. And really, I certainly apologize to you and to everyone else. I really should have done this for an hour and a half. Very, very, very great information. But for those of you that are joining us today, that have joined us for CEUs, I want to go over this again. Please, we're providing complimentary CEUs for licensed social workers and licensed professional counselors in the state of Texas. We're also offering a certificate of attendance. Please understand that these are for licenses in Texas. If you have a different license in Texas or a license outside of Texas, you're more than welcome to go through the process, get a certificate, submit it to your jurisdiction. But just please know there's no guarantees that they would take that. Today's webinar is worth 1 hour of CEU credit. You must have completed the entire webinar. You must be on right now, and and you can get off anytime you need to at this point. I do understand that you have other commitments. You must also complete the pre and post evaluation. I will put the post evaluation in the chat as soon as I finish reading these guidelines, and then we'll also send that out in a follow-up email as well. There's two post evaluations. One is a post test, which is a Survey Monkey, and the other one is a Google evaluation. We're going to need you to take both of those, if you would please. The Google survey will be up until a week from today, and please give us about 4 weeks after that to get the certificates to you. I'm going to stop there. I know Donnie had something that she would like to share real quick, if we could, and then we'll get back to questions if we can after that. I am going to stop the share and share my screen, if that's okay with you. And
thank you, Marty. And I'll be very brief because I know we are at time, but I want to express my gratitude to Marty, the Alzheimer's Alliance of Smith County. They are part of our Dementia Friendly initiative. And in addition to providing professional training through Dementia Friendly, we're also working to compile and share resources for people living with dementia and their family caregivers. In follow-up, you will receive a brief resource list. And I also wanted to let you know that we are getting ready to launch a series of workshops for small groups of family members who care for people with dementia. Building Better Caregivers will launch on July 25th. That's a virtual workshop series for family members. It will meet 1 day a week for 6 consecutive weeks. And the purpose is to help caregivers relieve their own stress, improve their self-care, as well as reduce stress for their care partner. So again, thank you all for joining us this morning. And I believe for those who are willing to stay, Julie is willing to answer some questions, correct?
Yes.
Fantastic. Thank you all.
So I had a question from David Adams. Are hallucinations associated with Parkinson's more related to medication side effect or to the actual disease process itself? Certainly medications can impact hallucinations, but in Lewy body disease, they tend to be early and definitely an organic part of the process. And later in Parkinson's, as the disease progresses, hallucinations are a part of the disease itself. Certainly not everybody with Parkinson's ends up with dementia, but it's not an uncommon progression of that disease. And then Mary Lawrence asked, can dementia stay mild and not progress to severe? It can if they have sort of a prolonged early stage. That does happen for some people where, 5-6 years down the road, they're still sort of struggling, but they're holding their own. And something, none of us gets out alive, right? So something's going to happen eventually. And they may die with dementia as well as live with dementia. So some people, do pass after a very prolonged sort of mild to moderate course of dementia. Jennifer Dooley asked, is it difficult to distinguish restless leg syndrome with REM sleep disorder? It could be on a sleep study because sleep studies often measure leg movements during sleep. And so people might be diagnosed with a primary leg movement disorder, which we think of as restless leg. But REM sleep tends to be characterized not only by movement of the legs, but acting out dreams. So people often set up and speak out, they'll mumble and talk, through the night. They'll knock things off the bedside table or, hit their partner. You don't see those type of behaviors with restless leg. So you can distinguish them, but sometimes early it can be hard. Do you think the foods that we eat affect dementia? Absolutely. We know that unhealthy lifestyles can increase our risk of developing dementia down the line, whether it's Alzheimer's or something like vascular dementia because of our lifestyle choices. So it definitely plays a role. Janice asked, is wobbling or being off balance a sign of dementia? It can be. Certainly there are people who have other, health conditions that are unsteady, but it's not uncommon as part of the dementia's effects on the brain to have changes in balance and gait. So how to get diagnosed? Sammy asked, how to get diagnosed, what kind of doctor or clinic to see? Oftentimes people will start with their primary care provider. Primary care providers are often very knowledgeable about early warning symptoms and doing evaluations that can pick up some concerns. And then you're going to end up with a neurologist, hopefully, or a neurology nurse practitioner with a neurologist to help navigate and identify a diagnosis. Guillermo asked, what is the time frame that should be looked at when filling out the fall scale? Follow your facility's policy, but typically it's within 24 hours and ideally much quicker than that. So at our long-term care facility, is considered a restraint to lock the brakes on their wheelchair. We utilize anti-rollbacks on wheelchair. Okay, I would say follow your facility's policy. I think, long-term care is a little bit different in that that's their home, that's where they are living. I'm thinking more about the acute care setting. If they're in a wheelchair, they're probably traveling to radiology, somewhere, and leaving, turning your back on someone who may be impulsive or not making good, confused. If it's not locked and they try to get up, it's a disaster waiting, it's a fall waiting to happen. So in acute care, I would be really conscientious about locking things. And then Lakeisha asked if not diagnosed with dementia is memory loss or repeating of comments, phrases, the number one indicator they should be tested. If they haven't been diagnosed and there's a fundamental change in their function, often short-term memory loss, repeating stories or repeating questions, yes, I would definitely share that concern with primary care, or if you're already involved with a neurologist, letting them know. Tantita said in a hospital setting versus long-term care setting, the differences in interventions that regulations allow. So I can only speak to the hospital setting because I'm familiar with long-term care, but I'm not aware of their policies. I would always say, follow your facility's policies. My advice would never supersede that. Follow your facility policies. And then somebody asked for the PowerPoint. I think that's going to be provided. And can issues with bladder and bowel control be related to some form of dementia? Yes. Bladder control problems often come along with other issues with aging. For men, maybe prostate enlargement causing frequency. For women, they might be having, stress urinary incontinence, urge urinary incontinence, but the brain being able to perceive those early, symptoms that the bladder or the bowels might send, the brain might not interpret those in a timely fashion. And then when it does, it is recognized, it's urgent. And so there may be accidents or, later in disease, there might be loss of perceptual ability to control those functions. In terms of assessing fall risk, how long after assessment should they be reassessed to monitor deterioration and changes in their mobility and risk? That's a great question. I would say when someone has early symptoms and concerns, those visits need to involve multiple people, usually primary care, neurology, a neuropsychologist who does really formal, detailed cognitive assessments. It might involve a psychiatrist if we're worried about coexisting depression or, mimics, things that can make somebody look like they're having cognitive impairment. And that team needs to be communicating with you frequently until you get some answers. Usually that's going to mean visits, every 2 to 3 months. If things are fairly stable, we have a plan in place, suspected diagnosis, then those may be 6 to 12 months. But they need to be frequent early on. And I think those are all the questions I have.
Yes. Julie, thank you so much. We certainly appreciate it, and I certainly apologize. Again, it's my fault, y'all. I should have.
I needed 10 more minutes.
Yeah. But it's all right. We usually do 1.5 hours, and I certainly apologize that I didn't do this one for that and give us the time, because look at the number of questions we have on top of the fact that we've missed a good portion of the presentation. I may talk to you about maybe even rescheduling and doing it for 1.5 hours and getting to the full version, which we just did that with another topic here recently for the exact same reason. And I certainly apologize. I want to thank you all for joining us. Just remember, I posted in the chat the post survey That's a SurveyMonkey survey. I've posted that link in the chat. I've also posted again the link for the slides that you're more than welcome to download. Julie has been kind enough to allow us to give you her email address in one of those slides in case you think of something after that you want to ask. You're more than welcome to send that to me and I can forward that on. Julie, thank you so very much.
Thank you so much for having me. I appreciate it.
We sincerely appreciate it. Rebecca, did you have anything you would like to say, or Donnie, before we close off?
Yeah, I thought it was a wonderful presentation, and thank you, Julie, so much for helping us put that together.
Thank you.
Thank you all.
Thank you all for joining us today. You all have a wonderful day, and please look forward to the follow-up email that will have also the links to the documents that Donnie talked about as well.